Hello everyone. My name is Shahid Nazir Mohammed, and I am going to give you a brief overview of this poster presentation on a theme relating to education, leadership, and management, which was presented at the British Blood and Transfusion Society, or BBTS, annual conference in 2017 in Glasgow, Scotland. The poster presentation is around the need to consider renal health in transfusion care and research to inform best practice. This work was a real opportunity to provide an overview of a broad subject, really, but with a focus on the long-term condition, chronic kidney disease. And so I'm going to give an overarching perspective on this important topic, again, in one way or another, really a retrospective overview. The poster presentation provides aims, background, some perspective on what is chronic kidney disease, clinical, why consider renal health in all patients who might require transfusion, not least if their hemoglobin is low, or whether they may have anemia, but also to factor in renal health as well, as part and parcel of why what would be expected from the laboratory teams, really, if patients would need red cells for transfusion. The post presentation also highlights and summarizes some clinical factors and the decision to transfuse, strategies for transfusion therapy, managing anemia in the chronically ill, chronically ill or complex care patient, and then some perspectives around leadership and management. And the poster then highlights some points of discussion and conclusions, and really encourage, hopefully should encourage colleagues in the profession to question more specifically the need for patients who might need transfusion, around transfusion, but not and also the care pathways that are available to their health clinicians who might be on the front line, making some of those decisions. So to begin with, really a bit of background. An estimated of 15 million patients in England have at least one long-term condition or chronic illness. And in this context, just from the outset, really, long-term condition, or LTC, and all chronic illness, or CI, these terminologies would be used synonymously. So one does not have superiority over the other. They are used in synchronization, really. So the numbers of patients with multiple LTCs or CIs has been set to rise from 1.9 million in 2008 to 2.9 million in 2018. Some patients cannot receive transfusion or red cells or other red cell or other blood components, or those components that make up hematology, owing to antibodies or antigens or being immunocompromised. The treatment and care guidelines for managing care in such patients ranges between centers. They may also range between different parts globally. The reference ranges can be a bit can cause problems between different laboratories wherever patients might be. So what one laboratory uses, for example, in the UK versus another laboratory that is based in the UK. On the one side of one level, the reference ranges are identical, but where certain aspects of care or healthcare are implemented, there may be differentiation between different regions, and that can cause its own cause its own complexities. In one way or another. So the aims of this work really were quite a few. To provide context of leadership and management in transfusion care and practices, to understand what further care is required for patients with LTCs or CIs, highlight with LTCs or CIs, highlight what practices would support the development of transfusion care guidelines, and for provide an understanding of what of treatment alternatives taking renal insufficiency into consideration. This work was literature review based or literature review focused. This is a synopsis on that aspect of this work as well. So 450 abstracts were identified having implementing certain keywords, and 200 and of the 450 abstracts identified, 274 papers were cross-examined using a critical appraisal skills program or CASP, and the version of the CASP was from 2015. 82 papers after implementing the CASP, 82 papers were evaluated to number one, really to understand what needs more consideration for patients with LTCs or CIs, what practices would help transfusion care guidelines, and three, provide an understanding of present indications for red blood cell transfusion or red cell transfusion. The themes derived. Number one, the themes derived are lack of renal health in transfusion care strategies, for patients with chronic illnesses, to managing anemia in the chronically ill or complex care patient. Number 3, alternatives and indications for red blood cell transfusion. And 4, the importance of research in leadership, the importance of research in leadership and management. The context around this then has been to highlight scientists or healthcare scientists have been needed, who can contribute through multidisciplinary teams, or MDTs, and just suffice to say, though the terminology MDTs has been used throughout different practice, varying areas of health practices within the UK. That terminology also used to refer to when clinicians on the front line, for example, would have meetings with those in the care of a patient, who also with other frontline colleagues. Technically speaking, MDTs refers to that, but in this work, MDTs really is has been to take into consideration the healthcare professionals, not just on the front line, but in those who are traditionally not for example, patient facing, and so in this regard, scientists and from a leadership management perspective, scientists are needed who can contribute through MDTs, using evidence-based understanding, prompting practice to become more rounded. And then with that perspective in mind, this will and should shift the paradigm of leadership and management, wherein future the challenge, future leaders or those who work in practice really challenge the status quo, and to inspire really and persuade frontline staff, colleagues, with certain with evidence, of course, evidence-based understanding, so that both the quality and the safety of patient care is ultimately increased, and thus there is more quality assurance, and patients should feel more find that beneficial and reassuring. From a discussion perspective, really, longitudinal studies are required to understand whether patients would benefit from alternative options rather than jumping straight to red blood cell transfusion, red cell replacement, red cell replacement options, i.e. red blood cell transfusion. So it's almost what's being highlighted is that along with the need to consider renal health, is to also preempt the onset of patients potentially who, for example, if there are those patients who are even known to have by healthcare teams, who are known to have low hemoglobin, for example, or because and or because they have issues where wherein their health or their background around health relates to either nephrology, hematology, or oncology, or any of those three disciplines, where those patients traditionally could fall into categories where they are more likely, or the probability of them having lower hemoglobin or other hematological components that are fall into abnormal ranges. This, along with renal insufficiency or potential renal insufficiency, there should be a link to preempt or pathways should prompt health professionals to preempt that, and in that context, finding alternative treatment options would be advantageous, and this work was presented in 2017. So since then, there have been more components that can actually help with as part of the patient's care plan, and more checks are in place before, for example, a patient might need, if they do need a red cell transfusion, but obviously where patients might have, for example, hemorrhage, may have lost a lot of blood through, for example, female patients who might lose blood through pregnancy, or other things, and patients who might have surgical procedure, etc. Obviously, where transfusion is concerned, then following the appropriate practices, then laboratory teams with the clinical teams should obviously look to transfuse that patient in obvious blood loss cases. Scientists with transfusion expertise or understanding are going to be needed to enhance the importance of renal health and sensitivity of laboratory tests through healthcare practices, and actually that can be achieved really through MDT, multidisciplinary team efforts. Modern laboratory practices are now extending or have been extending leadership functions across departments and teams in most organizations. Good management, however, will thus require input from colleagues at all levels to achieve a formal consensus and help form a robust renal transfusion guidelines. And in this regard, I want to highlight that there is, apart from what's highlighted in this poster presentation, the scientists are generally thus needed to take ownership to ensure safe and quality assured practices, and that there is understanding really at every level, allowing all to have a consensus, where as and when required. There is at the time of this work, there was the National Blood and Transfusion Committee, or MBTC. They came out with a particular statement. They say transfuse 1 dose of blood component at a time, and of course, if platelets are needed, for example, that platelets should also be transfused, and that should be the case in that should be the case, and then where that is needed and it is the case, that should be evident in non-bleeding patients, and reassess a patient clinically and with an action to get an update on the patient's hemoglobin, or and then really determine if another transfusion is needed, and this will help management in patients with who are unknown or not known to have in patients who are known to have renal insufficiency, and also can help get an understanding of where renal insufficiency needs to be should be monitored. So there are some particular references that I would recommend, though these are a little bit dated. It's good to I would like to think have a review on this topic from a retrospective perspective, and that is papers by Corwin, who's published work. One of his papers was in 1999, blood transfusion in the critically ill patient, and also another paper where he's published first in 1999, first blood transfusion first, do not harm. The first paper that he published in 1999 was published in one journal, and the other one was in a different journal, and then he publishes another one in 2005, Transfusion Practice in the Critically Ill, Can We Do Better? That was published in Critical Care Medicine. The poster presentation also summarizes a few references for further reading, but overall, the practices around renal, the need to consider renal health and transfusion care, and interlinking with research perspectives, or research to inform forms of practice. There is the bridging of those two, the bridging of the gaps is still where, at least from evidence-based perspectives, or evidence-linked perspectives, I should say, they're not really, that's not really harnessed in the laboratory. Laboratory scientists generally follow obviously UK, in the UK there's UK accredited schemes or initiative and that then translates into standard operating procedures, and standard operating procedures, although are evident from in one way or another, the understanding from an evidence base doesn't unfortunately does not translate into day-to-day practices from the laboratory side of things. So it would be beneficial or advantageous to see researchers where scientists who do their work from the laboratory side of things, from the laboratory perspective, become more intertwined with research practices, so that future practices, future areas of health where transfusion care is concerned, that actually that really does then become more multidisciplinary team effort. So there is a link between what goes on, what happens from a laboratory perspective, and that practice is transferred, and with those behind who would normally traditionally be functioning as scientists in the laboratory, work with that evidence-based understanding with those who are on the front line. That is kind of one of the a semi take-home understanding from this poster presentation. I like to leave it there for now. Thank you for listening. Any particular questions, then hopefully after listening to this presentation, feel free to follow up with the renal patient support group, who I would like to say thank you as well for allowing the opportunity to share this work with those who refer to the professionals who are linking that with day-to-day nephrology. Thank you.